Research indicates that a majority of individuals with BPD develop a substance use disorder in their lifetime. Some research suggests the figure could be almost 4 in 5, with about half of those having a drug dependency which spans their whole adult life, according to research carried out by Zannarini and colleagues. However, there is significant underrecognition of substance use disorders in BPD patients. For example, structured interviews suggest a mere 3.5% of alcohol abuse cases may be reflected in medical records. So why is substance abuse so common in BPD? Well, a leading hypothesis is the self-medication hypothesis. This hypothesis is based on the idea that the exceptionally high level of emotional distress that goes hand in hand with BPD compels those with the condition to resort to substances in the absence of more helpful coping mechanisms to quell overwhelming feelings of anxiety, emptiness, and fear, especially in relation to fear of abandonment. It is important to note that people with both BPD and substance use disorders are 4 times less likely to achieve remission over 6 years than those without a substance use disorder, highlighting the need for targeted intervention strategies, according to the research carried out by Zannarini and colleagues. In relation to this, a specialized variant of dialectical behavior therapy that targets both borderline personality disorder and substance use disorder has shown promising results. This approach emphasizes learning to tolerate distress and dialectical abstinence. Studies demonstrate that it increases abstinence days and reduces self-harm episodes. Follow me for more insights into BPD's causes, symptoms, and treatments.
Imagine perceiving the world through a lens that distorts reality, where every interaction feels tainted by suspicion. For those with borderline personality disorder, or BPD, this can be a daily reality. Hallucinations in BPD are actually longer lasting and more common than previously assumed, with some episodes persisting for weeks to months. Delusional convictions can also occur in BPD. A study by Zaccarini and colleagues, published in 2013, examined disturbed thinking in inpatients with borderline personality disorder and compared their quality of disordered thinking with other inpatients who were suffering from other axis 2 disorders, such as paranoid schizoid and antisocial personality disorders, but not BPD. The researchers categorized disordered thinking into 3 key types. First up, non-psychotic thoughts. This includes things like odd thinking, unusual perceptual experiences, and paranoid thoughts that don't quite reach the level of delusion. Next, we have quasi-psychotic thoughts. This category covers short-lived delusions and hallucinations that are tied to specific perceptions or thoughts. They're considered non-bizarre, which means, in theory, they could actually happen in real life. For example, someone might have fears of being followed, poisoned, or conspired against, and these usually come from misinterpreting real experiences. 3. True psychotic thoughts. These involve full-fledged delusions and hallucinations. The study revealed that individuals with borderline personality disorder exhibited significantly more disordered thinking across all 3 categories compared to non-borderline patients with other axis 2 disorders. Over a 16-year follow-up period, researchers identified 17 additional types of thinking and perception issues. Compared to those with other axis 2 disorders, people with borderline personality disorder had a notably higher risk of experiencing 11 specific types of thinking issues. These include overvalued ideas, recurrent illusions, and excessive suspiciousness, such as thoughts of being hated or targeted. There were also quasi-psychotic and true psychotic hallucinations, as well as quasi-psychotic and true psychotic delusions. Some individuals experience derealization, which is that feeling of being detached from reality, or depersonalization, where you feel disconnected from yourself. Ideas of reference were common too. For example, believing that negative feedback to a group is specifically directed at them in the absence of objective evidence. Some might have thoughts like, "I'm a terrible person," or "I'm irreparably damaged and my condition will never improve no matter what." Paranoid ideation and magical thinking also appeared, which is the belief that one's own desires, thoughts, and wishes can directly influence the real world. For example, putting a curse on somebody or using a voodoo doll. However, there is some better news here. Over the 16-year period of study, it was found that symptoms of these types of disordered thought in people with borderline personality disorder actually diminished, with the exception of true psychotic hallucinations. Recent research affirms that those with borderline personality disorder exhibit unique cognitive biases, which can clearly be a contributory factor to disordered thinking. Here are two examples. First, overcorrection bias. Patients with borderline personality disorder excessively adjust their beliefs in response to disconfirmatory evidence, like, for example, revising their self-image based on minor feedback. 2. Epistemic mistrust. Childhood trauma fosters a kind of pervasive distrust of social information which can sustain paranoid ideation. Individuals often discount positive interactions, maintaining beliefs like others will abandon me, even when there's plenty of contradictory evidence. Up to 80% of individuals with borderline personality disorder who experience psychosis report childhood abuse, and it's vital to note that the severity of trauma actually correlates with the intensity of dissociation and hallucinations. Recent studies continue to explore the cognitive and neurobiological underpinnings of disordered thinking in borderline personality disorder. For instance, a 2021 study highlighted the role of emotional dysregulation and cognitive distortions in really exacerbating symptoms. Improved understanding of these factors may lead to better targeted therapeutic approaches. Overall, this body of research really underscores the complexity of thought disturbances in borderline personality disorder and the need for individualized treatment strategies to address the unique cognitive patterns experienced by individuals with this disorder. The onset window, which is from puberty to the mid-20s, for both borderline traits and psychotic experiences, highlights adolescence as a key period for early intervention to prevent severe psychopathology. Should complex PTSD be named complex post-traumatic injury? Around 40 to 50% of people with borderline personality disorder in outpatient studies actually also meet the criteria for complex PTSD. The overlap is pretty high, mainly because they share a lot of trauma-related symptoms, though complex PTSD is often underdiagnosed in those with BPD. And while these disorders are definitely distinct, having a history of trauma really increases the likelihood of someone receiving both diagnoses. This brings up the question of whether complex post-traumatic stress disorder should actually be renamed complex post-traumatic stress injury. There are some key arguments both for and against making that change. We'll start by looking at arguments in favor of renaming. First, it reduces stigma. The term injury might be less stigmatizing than disorder, since it implies the condition is more like a wound that can heal rather than a kind of pathological malfunction. This could encourage more people to seek help. 2. Its neurological and biological basis. Trauma physically alters the brain, for example, changes in the amygdala, hippocampus, and prefrontal cortex. The word injury better reflects these neurobiological impacts, similar to how TBI, or traumatic brain injury, is understood. 3. Focus on healing and recovery. The word injury implies the possibility of rehabilitation, whereas disorder may sound more permanent or inherent to the person. However, there are also arguments against renaming it. For instance, framing it purely as an injury might lead to an overemphasis on biological treatments like medications, while underemphasizing psychotherapy and social support. Additionally, some survivors feel that injury doesn't fully capture the profound and pervasive impact of prolonged trauma, which affects identity, relationships, and even worldview. What do you think? Would renaming it help survivors feel more hopeful, or could it risk oversimplifying their experiences? If someone in our family has borderline personality disorder or BPD, we might wonder, will I get it too? The answer isn't simple. It's a mix of what we're born with and what we experience growing up. The genes we inherit can raise our risk of developing BPD. Studies show that if a close family member has it, our risk goes up. But it's really important to point out that there's no single BPD gene. Instead, many small genetic differences, especially differences that affect mood and stress-related brain chemicals, can add up to increase our risk. Think of it like inheriting a sensitive alarm system. Our emotions might just react more intensely to stress. Now let's consider the family environment's influence on whether a person develops BPD. Growing up with a parent who has BPD can be traumatic, even if they love us and try to do their best. Their intense emotions, unpredictable reactions, or difficulty parenting consistently can make it hard for us to learn healthy coping skills. It can leave us constantly walking on eggshells and teach us that relationships are unstable. This isn't about blame. Parents with BPD are often struggling themselves, but their parenting style can accidentally increase our risk of developing BPD. So bad childhood experiences like abuse, neglect, or even just constant chaos can, if they're severe enough, actually change how our genes work through something called epigenetics. It's kind of like your DNA gets these tags that flip stress genes on and calming genes off. And these changes can stick around into adulthood, making it a lot harder to control our emotions. This explains why two people with the same genetic risk might have different outcomes. The one who grows up in a calmer, more stable and secure home is pretty much guaranteed to do better. The good news is there's hope. Genes aren't destiny. Even with high genetic risk, good therapy like DBT and supportive relationships can really help rewire these patterns. And breaking the cycle is also achievable if we grew up in a BPD household. We can, for instance, learn emotional regulation skills our families might not have taught us, choose different relationship patterns, and get help processing childhood trauma. The bottom line is BPD runs in families because of what we inherit, like genetic sensitivity, how we're raised, and how trauma may have changed our biology, which is epigenetics. But remember, we have more power than our genes. With the right tools and support, the family cycle of BPD can stop with us.
BPD involves intense anger and difficulty controlling reactions, but men with BPD have more comorbid antisocial traits than women and are more prone to externalizing behaviors like impulsive aggression, substance abuse, and reckless behaviors, such as fighting, reckless driving, or gambling. This increases the risk of arrests or legal consequences. Women with BPD, on the other hand, are more likely to internalize distress, for example self-harm or eating disorders. There seems to be a neurobiological basis to this, as research suggests the MAOA gene variant predisposes men to externalizing behaviors like aggression, and women to internalizing symptoms under stress. Statistics indicate that about 1 in 5 men with BPD have comorbid antisocial personality disorder, compared to less than 1 in 10 women. This twin diagnosis increases risks substantially. Men with both BPD and ASPD commit 4 times more violent crimes than those with ASPD alone. It's essential to note, though, that men with BPD are often misdiagnosed with antisocial personality disorder because of overlapping impulsivity and aggression. It's also important to draw attention to gender biases. Aggressive behavior in men is more likely to be perceived as criminal rather than a symptom of mental illness, leading to punishment rather than mental health interventions. Women with BPD are more often directed toward psychiatric care, while men may end up in jail for similar impulsive actions. Men too may be less likely to seek mental health help due to stigma and masculine norms, increasing their chances of entering the criminal justice system instead of receiving treatment. Despite the high proportion of incarcerated men meeting BPD criteria, prisons lack trauma-informed care, focusing on punishment. It is also vital to point out that ASPD diagnoses are often misapplied to BPD men and can invoke eugenics-era narratives of untreatability, leading to harsher sentencing and denial of parole and rehabilitation programs. The use of gender-neutral assessment tools like the DSM-5-TR and screening for trauma history can significantly improve the chances of distinguishing BPD from ASPD in men. In essence, societal biases that criminalize their behavior rather than treating it as a mental health issue need to be re-examined. Early intervention and proper diagnosis can help avoid the risk of externalizing behaviors leading to legal problems, and there is a need to integrate mental health services into justice settings, such as trauma-informed prisons, including the development of male-specific therapies targeting anger and impulsivity, for example, aggression replacement training. BPD and confusing thoughts with reality. The feelings of those with BPD can be so overwhelming that they lose the capacity to view thoughts or emotions objectively, and to put these thoughts and feelings aside. In other words, their thoughts become absolute, unquestionable reality. As Professor Fonagai, a world expert on BPD, put it,
The sharp intensity of these feelings can lead to a state where the individual feels trapped, akin to solitary confinement as they grapple with emotions that feel intolerable. This perception of their thoughts as a direct reflection of reality can lead to impulsive behaviors as individuals desperately seek immediate relief from the unbearable emotional pain. At such times, individuals with BPD may struggle to articulate their feelings. This is because the experience of an intense emotional state can consume cognitive resources, leaving little room for reflection or verbalization. By the time they feel able to conceptualize their experience, the emotional intensity has dulled, leading to a disconnection between the feeling and the recollection of it. Dr. Wilfred Bion's work can provide insights into these mental processes. Bion emphasized the importance of containment as a mental process where thoughts and emotions are held and processed. Individuals with BPD often struggle with this containment, leading to a breakdown in thinking and an inability to manage emotional distress effectively. They cannot transform their thoughts into something manageable, resulting in overwhelming feelings that cannot be adequately verbalized or processed. So, in other words, there's inhibition of speech under stress because the body's heightened stress response activates the fight-or-flight system, which leads to cognitive overload in a part of the brain called Broca's area, which is associated with language production and speech processing. This lack of words during emotional crises leads to deep frustration as people try to share their experiences with others who might not understand. And since they can't articulate their feelings, they might end up acting them out in dysfunctional and self-destructive ways instead. Furthermore, once the emotional storm has passed, there is an inability to retrieve the full intensity of those experiences afterward, leading to a sense of disconnect and isolation. Providing a space where individuals can express their feelings without judgment can help in the validation of their experiences. Also, techniques that promote emotional regulation and cognitive restructuring can be beneficial. For example, dialectical behavior therapy, or DBT, is specifically designed to help individuals with borderline personality disorder learn skills to manage their intense emotions and improve their communication about these feelings. Furthermore, helping individuals develop a narrative about their experiences can offer them tools to articulate their feelings and circumstances better. This approach aligns with Bion's idea of making sense of emotional experiences through thought and language.
Why does the BPD brain seem sometimes to blur the boundary between love and hate? A fascinating study conducted by researchers at University College London, Zeki and colleagues back in 2016, helps to shed light on why those with borderline personality disorder may often swing between feelings of love and hate towards the same person. The study involved two conditions. In condition 1, participants looked at photos of people they loved. In condition 2, the same participants viewed photos of people they said they hated. Brain scans showed that some areas of the brain responsible for feelings of hate are also involved in feelings of love. Specifically, two brain regions were notably activated during both conditions. Firstly, the putamen. This area lit up when participants felt both love and hate, suggesting a shared neurological pathway for these intense emotions. And secondly, the insula. Similar to the putamen, this region showed activation during experiences of both love and hate. The activation of these two brain areas, namely the putamen and the insula, in both love and hate are universal, meaning these emotions share similar brain processes for everyone. However, in people with borderline personality disorder, the connection between them is disrupted and heightened, possibly contributing to the typical love-hate patterns they experience in relationships. In conclusion, we can say that whilst the insula and putamen activate for love and hate in all individuals, in borderline personality disorder, dysregulation of these areas and the way they connect may help to perpetuate a pathological cycle whereby love and hate become indistinguishable at the neural level, fueling relational chaos. Dialectical behavior therapy teaches us emotion regulation, distress, tolerance, interpersonal skills, and mindfulness to break destructive relationship patterns. Alternatives like mentalization-based therapy and transference-focused psychotherapy help us understand emotions and integrate polarized views of others, while schema therapy addresses deep-seated beliefs fueling instability.
Those with BPD have a level of insight into their condition which is tormenting but, at the same time, also potentially extremely therapeutically helpful, as it's this painful self-awareness that often drives people with borderline personality disorder to finally reach out for help. In borderline personality disorder, the tragedy isn't ignorance of suffering, it's the excruciating insight into it. Compared with other personality disorders like narcissistic and antisocial personality disorders, those suffering from borderline personality disorder have more insight into their condition, are more distressed by it and, as a consequence, are more likely to seek help for it. In fact, over 75% of those with borderline personality disorder seek therapy voluntarily, which is actually the highest rate among personality disorders. Furthermore, 85% show symptom remission after 10 years of treatment. To shed light on disparities between different personality disorders, it's helpful to distinguish between egosyntonic and ego-dystonic mental health disorders. When a condition is egosyntonic, the accompanying thoughts and behaviors feel right and align with self-image. Also, there's no distress. The person with the egosyntonic condition sees nothing wrong, thinking, "This is just who I am." For example, a narcissist sees their grandiosity as deserved. However, when a condition is ego-dystonic, its accompanying thoughts and behaviors feel wrong and clash with our self-image. We recognize that these thoughts and behaviors are harmful and unwanted, thinking, "I hate that I do this." For example, someone with borderline personality disorder feels crushed, humiliated, and ashamed after an intense emotional outburst. Borderline personality disorder, or BPD, is predominantly ego-dystonic. That means symptoms like emotional lability, chronic emptiness, and self-harm are experienced as invasions of our true self. Furthermore, hyperactive amygdala and prefrontal cortex dysfunction really amplify emotional pain, making these symptoms almost impossible to rationalize as normal. This stands in contrast with narcissistic personality disorder, or NPD. People with NPD often have what's called an ego-syntonic shield. To themselves, their grandiosity, entitlement, and lack of empathy actually feel justified and protective. In fact, only about 14% perceive their traits as problematic. Now, there is an exception. The covert narcissist does experience shame, but usually attributes their distress to others' so-called failure to admire them, rather than to their own pathology. Also, unlike those with BPD, people with narcissistic personality disorder tend to be treatment avoidant. Fewer than 15% seek help for NPD itself, and when they do, it's usually because of comorbid depression or anxiety. Furthermore, 80% terminate therapy prematurely if their initial admiration-seeking doesn't work out. And now, let's turn to how antisocial personality disorder, or ASPD, compares. In the case of ASPD, deviance is conscious, and traits and behaviors like callousness, manipulation, and law-breaking tend to align with self-identity. Kind of like, "I take what I deserve." Only about 20% report any guilt over their actions. 35% engage with treatment only when it's court-mandated, and intrinsic motivation is pretty rare. Only 5 to 10% complete voluntary treatment, and 65% recidivate within 3 years. The self-awareness of those with BPD, especially when compared to people with NPD and ASPD, really has great therapeutic benefits. Therapies like dialectical behavior therapy can help validate distress while building skills to regulate emotions, and the prognosis is actually good. 85% achieve symptom remission within 10 years.
Paradox of borderline personality disorder social perceptions. Those with borderline personality disorder notice emotional changes in others faster than those without borderline personality disorder, but then are far more likely to misinterpret those changes. Technically, this can be referred to as a dual processing anomaly in social cognition. Studies show that people with borderline personality disorder detect subtle emotional shifts faster than healthy controls. For example, they recognize anger at lower intensity levels, and EEG studies indicate hypervigilance during early visual processing of faces. Furthermore, eye tracking and functional MRI studies reveal faster attention to emotionally salient regions, such as the eyes of angry faces. But here's the paradox. When interpreting these emotional changes, those with borderline personality disorder show a negative bias. Neutral faces are frequently mislabeled as angry or rejecting, and studies confirm that those with BPD attribute negative emotions to neutral expressions 2 to 3 times more often than those without BPD. Under stress, such as during social exclusion, individuals with BPD over-attribute intentions to others, for example, inferring malice from ambiguous cues. This is referred to as hypermentalization. Research also shows that neutral faces are more likely to be interpreted as signaling personal rejection. Studies show those with BPD rate neutral social interactions as more disagreeable, more hostile, more ambivalent, and more unsupportive, which reinforces isolation and negative expectations. Individuals with BPD also report feelings of deep shame as a dominant response to perceived social slights, perpetuating cycles of withdrawal or aggression. As a result of such difficulties, people with borderline personality disorder have been found to have smaller, less interconnected social networks, and a higher likelihood of forming close bonds with socially peripheral figures, like former partners. This in turn reduces access to stabilizing relationships. So what can be done to reduce these misinterpretations? One technique is known as cognitive remediation. This involves teaching patients to check the evidence for interpretations. For example, asking, does this person's facial expression really mean they hate me and want to do me harm? This approach has been shown to reduce misattributions. Another strategy is social rebuilding. This involves group therapies focused on rebuilding relational skills, such as learning to trust non-threatening cues. The struggle to trust one's own perceptions is a core feature of borderline personality disorder. Growing up in an environment where feelings, thoughts, needs, and interpretations of events were consistently dismissed, denied, punished, or ignored, and being constantly told things like, "Stop crying, it's not that bad," or "You're too sensitive," or even "That didn't happen and you're imagining things," may have taught us a devastating lesson. My inner experience is fundamentally wrong, unreliable, or unacceptable. Also, many individuals with BPD have histories of having been gaslighted, meaning being told their reality is false, or of traumatic betrayals by trusted caregivers. This directly attacks the foundation of trusting our own judgment. After all, we might ask ourselves, if they manipulated me so profoundly, how can I ever trust my read on people or situations again? We learn not to rely on our own internal compass, and our own perceptions become suspect. The matter can be further complicated by having a fragmented rather than integrated sense of self. When the self is fragmented into distinct, often conflicting self-states, like for example the terrified child state and the numb dissociator state, there is no consistent, integrated self experiencing the world. Indeed, different self-states may have different perceptions, emotions, and memories. What feels true and real in one state, such as intense abandonment terror, whilst in the terrified child state, might feel alien or unreal in another, like a detached, numb state. This inconsistency makes it extremely hard to develop a stable, trusted sense of how we see things. Then there's the emotional tsunamis to factor in. When emotions are this overwhelming, they powerfully color perception. Fear sees threats everywhere. Shame sees judgment in every glance. Sadness sees hopelessness in every situation. But having the insight to know our emotions are extreme can lead us to doubt any perception formed under such intense emotional duress, when neutral or ambiguous cues can be catastrophically misinterpreted as rejection, criticism, or betrayal. We are constantly forced to wonder, am I seeing this clearly, or is it just my emotions taking over and my BPD making me paranoid? This combination of factors creates an unsettling internal landscape. We may find ourselves asking ourselves never-ending questions like, am I overreacting, or is this real? Or did they mean to hurt me, or am I just being sensitive? Or even, what do I actually think and feel, and who am I anyway? The good news is that various therapies can help. Mentalization-based therapy, or MBT, is a type of psychotherapy that focuses on improving a person's ability to understand their own and others' mental states, including thoughts, feelings, and intentions. Transference-focused psychotherapy can help individuals integrate fragmented or split-off parts of their self-perception and emotional experience, ultimately leading to a more cohesive sense of self. Schema therapy can help with challenging core beliefs, and experiencing consistent validation within the therapeutic relationship can help us to slowly relearn the ability to trust others. Finally, learning dialectical behavior therapy skills such as check the facts can help us to challenge emotionally driven perceptions against objective evidence.
The BPD rage-shame cycle describes a self-perpetuating loop of intense emotional reactions. It primarily involves outbursts of anger or rage, followed by deep feelings of humiliation, worthlessness, and self-hatred, which we call shame. An event occurs that is perceived as threatening, invalidating, rejecting, or abandoning. This could be real, perceived, or even just anticipated. Due to the core BPD features of emotional dysregulation and fear of abandonment, this trigger causes an intense surge of overwhelming emotion, often fear, panic, hurt, or frustration. The overwhelming emotions quickly escalate into intense anger or rage. This rage can feel uncontrollable and explosive. It might manifest as verbal or physical aggression. The rage is often a desperate attempt to express the unbearable inner pain and fear, and to make the other person understand just how deep their emotional distress really is. Once the intense rage subsides, which can happen relatively quickly, the individual is often left facing the consequences of their outburst. This, in turn, leads to overwhelming shame, humiliation, guilt, and regret over what was said or done, along with intense self-hatred and a real fear of the damage caused to relationships. Shame is a core feature of BPD. The behavior during the rage phase often clashes violently with the person's own values or desires for connection, which can trigger profound self-condemnation. They start to fear that the outburst confirms their deepest fears of being bad, unworthy, and unlovable. So, to cope with the crushing shame, the person might withdraw and isolate themselves, hiding away and becoming uncommunicative, or even push people away just to avoid further rejection or judgment. This withdrawal can lead to increased isolation and feelings of abandonment, restarting the cycle. A new trigger, whether it's real or just perceived, occurs, igniting the intense emotional pain and leading right back to rage, and so the cycle repeats. Experiencing this cycle is incredibly painful for the person with BPD, and can be frightening or even damaging for those around them. It's really important to remember that this is a symptom of profound emotional suffering, not a character flaw. Breaking this cycle is challenging but possible, and it often requires professional help. Dialectical behavior therapy, or DBT, specifically teaches skills to survive intense emotions without resorting to destructive behaviors like rage. It offers skills to understand, label, reduce vulnerability to, and modulate intense emotions, as well as skills to communicate needs and set boundaries assertively and in a healthy way, which reduces triggers for rage and shame. Plus, it teaches skills to observe thoughts and feelings calmly, without letting them take over.
Relationship conflict hits differently with BPD. It's not just in the head, it's coursing through the veins. Research pinpoints cortisol as the key hormone spiking during BPD conflict responses. The response to interpersonal conflict isn't drama, it's a neurobiological reality rooted in sensitivity to rejection, abandonment, or invalidation. Cortisol, often called the stress hormone, is part of our body's survival system. During threat, real or perceived, our hypothalamus triggers a chain reaction that releases cortisol to mobilize energy. These cortisol spikes may spike higher and faster in those with BPD than they do in non-BPD individuals. This is because the BPD brain interprets relational rupture as danger. The cortisol surge is the body's way of preparing to fight for connection or flee from harm. However, after chronic stress, those with BPD can also do the opposite of producing too much of this stress hormone. They can underproduce it. This is sometimes called the exhaustion response, and is our bodily system's way of conserving energy. It has also been theorized that whether we overproduce or underproduce cortisol may depend on the type of conflict we are facing. Generic stress may blunt the person with BPD's cortisol response, while personal conflict, like a relationship clash, leads to an intense spike. This is because our body prioritizes what we deem most threatening. Research doesn't pathologize such cortisol responses, it contextualizes them. You see, these cortisol patterns often stem from childhood trauma or invalidation, which wires the brain to perceive conflict as high risk. The person with BPD's nervous system has learned through deeply painful experiences to constantly scan for social signals of rejection such as voice tones and facial expressions. This isn't a disordered response, it's our body using past data to try to protect us now. Distress tolerance skills, learned in dialectical behavior therapy, including tip skills. Temperature, intense exercise, paced breathing, can significantly lower cortisol. Follow me for more insights into BPD's causes, symptoms, and treatments.
Emotional numbing and borderline personality disorder, often described as feeling like a robot or watching life through a fogged window, is not indifference, but a dissociative defense mechanism against overwhelming emotional pain. It manifests as a sense of detachment from emotions, body, and reality. This numbness arises when the brain, flooded by trauma or chronic stress, shuts down and prioritizes survival over emotional processing. In neurobiological terms, hyperactivity in the amygdala, emotional reactivity, and reduced activity in the prefrontal cortex, emotional regulation, in response to acute stress, creates a circuit overload that forces the mind to shut down. This is why a person with borderline personality disorder, BPD, may experience repeated patterns of intense emotional highs, hyperarousal, spelt with an E, and deep emotional lows, hypoarousal, spelt with an O. Hyperarousal, spelt with an E, involves feelings of anxiety, anger, or excitement, while hypoarousal, spelt with an O, refers to feelings of numbness, emptiness, or depression. These cycles can affect their mood and behavior significantly. A person with BPD might describe emotional numbness as a kind of mental shield, where they mechanically perform daily tasks, for example, work, socializing, but feel no genuine connection to their actions or others. This is sometimes referred to as structural dissociation and involves the splitting of the self into a functional persona, handling daily life, and a wounded self, holding repressed pain, exacerbating the robotic detachment. Numbing often follows periods of hyperarousal, rage, despair, as the psyche seeks equilibrium. What are the consequences of this numbing? Well, one effect can be termed autopilot living, where tasks are mechanically completed without joy or purpose.
I'm a robot programmed to function.
Another effect is social withdrawal and avoidance of intimacy due to fear of emotional exposure.
I'm a fraud in every relationship.
Finally, prolonged numbing erodes self-awareness, causing confusion about values, desires, or even physical needs. For example, forgetting to eat. Treatment focuses on rebuilding emotional tolerance and identity. Dialectical behavior therapy, DBT, teaches mindfulness and distress tolerance to gradually thaw numbness, whilst schema therapy addresses the detached protector mode, helping individuals reintegrate suppressed emotions. Also, grounding techniques can be used to help anchor patients in the present, countering dissociation. Follow me for more insights into BPD's causes, symptoms, and treatments.
Imagine being homesick but with no home to go to. Dr. Marsha Linehan, creator of Dialectical Behavior Therapy, DBT, recalls her own BPD experience in the following words. That gulf between the person I wanted to be and the person I was left me desperate, hopeless, deeply homesick for a life I would never know. This homesickness reflects a primal yearning for emotional safety, consistency, and belonging that was never established in childhood. Research shows a large majority of people with BPD report childhood trauma, abandonment, or disrupted attachment, leaving them without a foundational sense of home. This can lead to a feeling of having a void within and chronic emptiness, a kind of spiritual homelessness resulting in hypervigilance to danger and an inexorable craving for emotional safety and security. Indeed, 60 to 80% of BPD patients report persistent emptiness, described by Linehan at the age of 17 as feeling like my soul was tossed somewhere askew. Feelings of emptiness like these can result in identity chameleonism, which refers to the adoption of others' personalities to borrow a sense of self. Impulsive escapism, such as substance abuse, binge spending, or binge eating, are often attempts to fill the void. According to Linehan, healing begins by radically accepting what she calls the unbridgeable gulf between the life expected and the life given. Radical acceptance is a core principle of her dialectical behavior therapy. This, according to Linehan, replaces shame with self-compassion. Recent research underscores that dialectical behavior therapy, or DBT, is an effective treatment for borderline personality disorder, significantly improving emotional regulation, interpersonal relationships, and reducing impulsivity and mood instability. Additionally, DBT has been linked to decreased hospitalization rates, demonstrating its effectiveness in managing crises. Long-term studies suggest that the mental health benefits achieved through DBT can persist over time, solidifying its role as a leading evidence-based therapy for BPD.
What if entire chunks of your childhood were missing, not just forgotten, but erased by trauma? For many with borderline personality disorder, BPD, memory gaps aren't just normal forgetfulness, they're survival mechanisms. Many people with BPD report significant childhood memory loss. But these aren't just ordinary lapses. They're often the brain's way of burying unbearable pain. We try to recall our childhood, but it's like flipping through a photo album with half the pictures torn out. Dissociation plays a key role in this. Dissociation is an extremely common symptom of BPD and refers to a mental process where a person disconnects from their thoughts, feelings, memories, or sense of identity. Common features of dissociation include detachment from reality, emotional numbness, and, most importantly, memory gaps. Many adults with BPD who dissociate may also have dissociated in childhood as a coping mechanism in response to experiences such as emotional or physical abuse or witnessing violence. Indeed, some with BPD report entire childhood periods as blank, with only fleeting, fragmented images or emotions remaining. From a biological perspective, traumatic experiences, particularly in childhood, can hinder memory encoding by triggering a heightened stress response. This response elevates stress hormones like cortisol, which can impair the hippocampus, the brain area crucial for forming new memories. Prolonged high cortisol levels can not only compromise hippocampal function, but may also alter its physical structure. Approaches like dialectical behavior therapy, DBT, and trauma-focused therapies, for example EMDR, can help individuals process repressed memories and reduce dissociative symptoms. Follow me for more insights into BPD's causes, symptoms, and treatments.
Borderline personality disorder is psychiatry's master of disguise, mimicking depression, bipolar disorder, and PTSD so well that clinicians very frequently miss it. A large-scale 2020 analysis found that only 20% of BPD cases are correctly diagnosed at initial assessment, with many mislabeled as major depressive disorder or bipolar disorder. This is because BPD is a highly complex condition. Its complexity lies in its symptom mimicry and also in diagnostic overshadowing. BPD shares overlapping features with other psychiatric disorders, leading to misdiagnosis or delayed diagnosis. 3 psychiatric disorders it overlaps with are as follows. 1. Bipolar disorder. Both disorders involve emotional instability, but the nature differs. In BPD, mood shifts are rapid, reactive to interpersonal stressors, and often include chronic feelings of emptiness. Whereas in bipolar disorder, episodes of mania and depression last days to weeks, are less situation-dependent and involve distinct biological rhythms. 2. Major depressive disorder or anxiety disorders. Depression in BPD is very common, but often manifests differently compared to standalone major depressive disorder. In BPD, it is especially marked by rejection sensitivity, chronic emptiness, and self-harm. Anxiety in BPD is largely interpersonally driven, such as fear of abandonment, rather than the more generalized worry observed in generalized anxiety disorder or panic attacks as in panic disorder. One study found that 96% of BPD patients had a lifetime mood disorder. 3. BPD versus PTSD or complex PTSD. Similarities in these conditions include shared trauma roots, hypervigilance, and emotional flashbacks. BPD involves fear of abandonment and sudden rage or shame, while PTSD focuses on threat detection and intrusive memories. However, there are key differences too. BPD includes identity disturbance and chronic self-harm, whereas PTSD focuses on avoidance and numbing. Diagnostic overshadowing occurs when a more recognizable disorder dominates clinical attention, causing BPD to be overlooked. This leads to underdiagnosis of BPD and ineffective treatment plans, and a worse prognosis as untreated BPD leads to higher rates of hospitalization, self-harm, and suicidality. A longitudinal study showed that delayed BPD diagnosis increased the risk of chronic disability by 3-fold. Were you misdiagnosed? Leave a comment.